So I just want everybody to know that Tim asked me yesterday how he can join our minimally invasive society. So the other thing is, it's just getting back to what's been said again and again, especially with forefoot deformity. You really need to know what the patient wants. And so I acknowledge that lining up the sesamoids perfectly where they're supposed to be is important, but radiographically, but I'm not sure that it correlates with patient outcomes and what patients are looking for. So these are, the bane of my existence, and have been until very recently. All of these patients have tried these, various options with limited success, and then they come to have it fixed. So why would we do the surgery like this when we could do it like this? I mean, honestly, how can anyone argue against a minimally invasive technique? So again, want to acknowledge my mentors, Joelle and David, and other members of GRETMIC who not only convinced me, but continue to teach me, and I'm very appreciative. So these are all the options. You can do a million things to the little toes in percutaneous ways. I'm just gonna really talk about the bony options. So we have a phalangeal deformity, primarily in the coronal plane. You take that little wedge out of the base of the proximal phalanx, green stick the toe over, and you have a correction. So this is an example of that. Minimal incisions, patients back in the shoe. Very, very effective. If you have a more sagittal deformity, you can take a plantar wedge osteotomy out of the base of the proximal phalanx, release the MTP joint and the PIP joint, and then cut the middle phalanx, performing a dorsiflexion osteotomy, and you have your correction, green sticking it again. This is an example of one of those procedures where I'm making my incisions. The MTP release has been done, releasing the PIP joint. Let me turn down the light. That's where I make my incision for the phalanx osteotomy, and then this is cutting the osteotomy. And then, can you run the second, is there a way to run the second video on that last one? No. Okay, hold on, let me try it again. Oh, there we go, thanks, Pete. So then I'm green sticking the toe over and get the correction. So what about the crossover toe? So dual deformity, these are so hard to treat. I've tried everything. Every single thing that's been published, I have tried. And the first time I had the guts to try this osteotomy, and it was really fairly recently, I literally high-fived my PA. It was so effective. So you make this oblique cut at the proximal phalanx, and the toe slides, and it's like a miracle. The toe completely reduces through this very small incision. I swear, if you just try it, you will jump for joy and high five whoever is working with you. And even the anesthesiologist was amazed. The first time I did it, it was just a pure joyous moment. And there it is, and that's what happens. And so you shorten it, and I'm sure what's happening is you're reducing the plantar plate by decreasing the tension in the toe, but it works, and it works great. Here it is again. And I had done a percutaneous chevron Aiken on the patient. So this is an example, pre-op, intra-op after the incisions were closed, and then post-op, and that was 2 weeks post-op. And we do these funky dressings to keep the toes in place, so you see kind of bigger spaces there, but those are the incisions for a medial crossover toe. It's pretty sweet. You have to hold the reduction, and again, I alluded to this with these actually wet dressings that dry and create this sort of paper mache-like crepe. Sometimes I use stitches to hold my PIP joint in place, and I'll use a stitch on the plantar aspect, trying to avoid pins when I can. Sometimes pin fixation is necessary. So in this patient, I did a phalangeal osteotomy. I actually did a lateral and plantar closing wedge and reduced the deformity, and I pinned it because she lives far away and couldn't come back in between her 2 and 6 week appointment. This is another example of somebody I did actually the other day. I've done bilateral feet. And if you look at sort of the head-on view, that's right after I cut. All I had done was just make the phalangeal cut. So post-operative care is immediate weight bearing, dressing changes, strapping for 6 weeks. And it's just another tool for your toolbox, but you guys should try it. It's life altering for people who are dabbling in minimally invasive surgery. Thank you.